Okay, since it is 9:50, I'm going to go ahead and get started. So while I'm sharing my screen, I'm not able to see the chat box. So if anyone has any questions, comments, concerns, go ahead and put that in the chat, and then hopefully one of my moderators can help me out and let me know if any of you guys have anything you'd like to say. But other than that, I'm going to go ahead and get started. So hi, everyone. Thank you for having me. Thank you for attending. My name is Chloe Etzer, and like many others in this field, I believe that disease prevention is one of the greatest emphases we can educate the public on. So as you also know, maternal nutrition is directly related to a fetus's outcome later in life. I wanted to research more about preeclampsia because I want the public to know how important their actions are even before they start to raise the next generation. So a little introduction into preeclampsia. Preeclampsia is categorized as having a blood pressure greater than or equal to 140/90 on 2 occasions, at least 4 hours apart, as well as the presence of protein in the urine after 20 weeks of gestation. However, newer guidelines now recommend not waiting for the proteinuria to appear before diagnosing. It occurs in 2 to 8% of all pregnancies, but it is responsible for 25% of maternal deaths and perinatal morbidity and mortality. So the road to preeclampsia begins before conception and is unfortunately not reversible. It includes these factors in the mother, listed here, as well as factors from the father, such as advanced paternal age, paternal obesity, and family history of early onset cardiovascular disease. For many women, preeclampsia is resolved by itself after the delivery of the infant. However, some women develop hypertension and cardiovascular diseases after delivery, and it also has lasting effects on the growing infant. Impairment of placental vascularization limits efficient delivery of nutrients and oxygen to the fetus, which leads to fetal growth restriction and impairing cognitive development. Preeclampsia develops in a 2-stage process. The first stage is hypertension, causing a poorly perfused placenta, or a placenta that is not getting adequate blood supply. The hindered blood supply then causes stage 2, which is called maternal syndrome. In this, the mother's body creates an inflammatory response against this injury. This causes a cascade of events involving oxidative stress. This image here displays the difference between a non-pregnant, a preeclamptic, and a typical pregnant female anatomy. The biggest difference you can see between the preeclamptic and the typical pregnant anatomy is that the typical pregnancy is getting an adequate blood supply to the placenta, while the preeclamptic side is significantly hindered. Going into our first study, we cannot talk about disease prevention without mentioning vitamin D, right? So this first study is titled "The Effects of Vitamin D Supplement on Prevention of Reoccurrence of Preeclampsia in Pregnant Women with a History of Preeclampsia." They started out by explaining that low maternal vitamin D stores may contribute to low birth weight, small for gestational age infants, and increased risk for maternal comorbidities. The article explains that since vitamin D is needed for proper immune function, low serum vitamin D contributes to overexpression of Th1 inflammatory cytokines. The aim of this study was to determine the effect of a vitamin D supplement on reducing the probability of recurrent preeclampsia. Their inclusion criteria were women who were receiving prenatal care in this specific hospital the study took place. They also had to have a history of preeclampsia in previous pregnancies and had to have a serum 25-hydroxyl vitamin D level equal to or higher than 25 nanograms per milliliter. Their exclusion criteria had to do with pre-existing conditions that might conflict with the study, as well as the participants willing to participate. After screening with the criteria, the study was left with 142 participants with an average age of 31 years, an average gestation of 14 weeks, an average of 3 previous pregnancies, and an average blood pressure of 115/74. 30% of these women were from rural locations and 70% were from urban ones. None of these participants had previously taken supplements or had a family history of preeclampsia. Their methods were simply randomly splitting the 142 participants into either an intervention group or a control group. The intervention group was given 50,000 international units of vitamin D3 or cholecalciferol once every 2 weeks. The control group was obviously given a placebo. Both groups were treated until the 36th week of gestation. Neither the physician nor the patient knew about the administration of a drug or a placebo, hence why it is a double-blind study. The results found that the intervention group had a significantly lower probability of developing preeclampsia than the patients in the control group. This significance is highlighted on the image on the left. The article went on to discuss the 2 stages of the onset of preeclampsia and said that the vitamin D supplement implementation helped reduce the inflammatory immune responses that causes the abnormal implantation and hypertension. They also mentioned how proteinuria is associated with vascular endothelial growth, and active vitamin D can also help regulate these processes. They concluded the study by stating that vitamin D supplementation in pregnancy could help reduce these conditions and suggested that a supplement of 4,000 IUs daily is effective in maintaining normal plasma level of serum vitamin D, which is greater than 32 nanograms per milliliter without toxicity. The strengths of this study were that it was an actual intervention trial with a placebo for the control. It was also a double-blind study to enhance its validity. The limitations were that the treatment might have started too late within the pregnancies to really claim prevention, and 70 participants is still pretty small for an intervention group. The study received a positive rating for its relevance, its intervention protocol, having comparable groups, and for being free of bias. My next study is titled Nutrition Status Among Women with Preeclampsia and Healthy Pregnant Women. The study also talked about preeclampsia's prevalence and its contributing factors. Instead of being an intervention study, this study aimed to compare the nutritional status of women with preeclampsia with healthy pregnant women. Their inclusion criteria for this study were simply women at least 19 years of age and at least 16 weeks of gestation. Their exclusion criteria were similar to the other study, which are pre-existing conditions that could alter the results of the study. The 2 groups they compared were labeled the preeclampsia group and the control group. The preeclampsia group were 30 pregnant women who had been hospitalized with a preeclampsia diagnosis. The control group were 30 pregnant women visiting the hospital for a routine checkup. This study used a questionnaire to determine the general features, physical activity level, food consumption frequency, and diet habits of these women. After collecting data from the questionnaire, the study found a few significant differences between the 2 groups. So compared to the healthy women, the women with preeclampsia were shown to have higher pre-pregnancy BMI, total cholesterol levels, and total triglyceride levels. They were also shown to have a lower weight gain during pregnancy, fetal birth weight, and lower folic acid levels. In terms of intake, the preeclampsia group had higher energy and carbohydrate intakes, but they had lower total dietary fiber intakes than the healthy women. This table simply displays the results from the general features of pregnant women, with pre-pregnancy BMI, weight gain during pregnancy, total cholesterol and triglycerides, and folic acid levels with their significant p-values. So BMI, total cholesterol, and total triglycerides were all significantly higher in the preeclamptic group, and folic acid levels were significantly lower. This next table displays the results from the dietary requirements meeting percentages, with total energy and total carbohydrates being significantly higher in the preeclamptic group, and total fiber intake being significantly lower. The study discussed about how certain conditions, such as obesity and hyperlipidemia, prior to pregnancy can lead to preeclampsia, which is why they were prevalent in the preeclampsia groups. Like certain comorbidities, this study displayed that dietary habits and intake can also be indicative of preeclampsia. The strengths of the study were that the two groups of women that were compared were all from the same area to prevent variations in diet. They also had a lot of exclusion criteria to prevent even more variations that could skew the results. The limitations were the small sample size, being 30 women in each group, and the fact that they used a questionnaire instead of something more concrete like lab values. Questionnaires can be open to interpretation and may lead to inaccurate results. The study received a positive rating because of its use of reliable tools, having comparable study groups, and for being free of bias. This last study is titled Dietary Factors Associated with Preeclampsia or Eclampsia Among Women in Delivery Care Services in Addis Ababa, Ethiopia, a case control study. This study wanted to focus on the burden of preeclampsia in developing countries, and as its title suggests, it aimed to assess the dietary factors associated with preeclampsia or eclampsia among women in Ethiopia. With this study, their inclusion criteria were the typical diagnostic criteria for preeclampsia, being the increased blood pressure and presence of protein in the urine. Their exclusion criteria were women with known hypertension and renal disease before the study and prior to the start of their pregnancy. After collecting the participants, the study ended up with 81 cases and 162 controls. The average age of these participants was 27 years. After conducting this study, there were several factors that they found to be associated with developing preeclampsia. These factors were having preeclampsia or eclampsia in previous pregnancies, drinking coffee daily, being nulliparous or never having children before, and having less than 1 year in between pregnancies. The good news is that even though there were factors found that contributed to preeclampsia, they also found some factors that actually prevented preeclampsia. These factors were receiving nutritional counseling during their antenatal care follow-up and increased fruit and vegetable intake during pregnancy. The study suggested that eating fruits and vegetables are protective factors against developing preeclampsia because of their high vitamin C and vitamin E content. Vitamin C and E's ability to prevent preeclampsia needs further research, but it is known that the presence of high antioxidants in the plasma and placenta prevents hypoperfusion or hindered blood flow. The strengths of this study were the use of both bivariable and multivariable analyses, as well as a variance inflation factor to assure the results' validity. The limitations were the data collection being a questionnaire. Not only was the questionnaire conducted through a face-to-face interview, but it was also translated from English to Ethiopia's official language, which can lead to misunderstandings and skewed results. The study received a positive rating for its lack of bias, having comparable groups, and using valid tools. A systemic review conducted by Fogarty et al. Explained how as pregnancy progresses, the requirements for vitamin D increases. So consequently, any pre-existing vitamin D deficiency can worsen. Their study found that vitamin D supplementation was inversely associated with an increased risk of preeclampsia. A compromised maternal vitamin D status has been associated with a twofold increase in congenital heart defects in offspring and a higher incidence of fetal miscarriage, gestational diabetes, bacterial vaginosis, and perinatal depression in mothers. Inadequate plasma 25-hydroxyvitamin D levels during early pregnancy are associated with increased changes in total cholesterol and low-density lipoproteins, or LDL cholesterol, and an increased risk of hypertensive disorders. In a cohort study performed on 13,806 pregnant women, maternal vitamin D deficiency at 23 to 28 weeks of gestation was strongly associated with an increased risk for severe preeclampsia. Another review by Devarshi et al. Wrote about the importance of omega-3 fatty acids, specifically EPA and DHA. These fatty acids were widely recognized to impact fetal and infant neurodevelopment, but it is said that up to 95% of childbearing age women and pregnant women do not meet the recommendations for EPA and DHA intake. Several factors influence the availability of EPA and DHA to fetal tissues, such as dietary intake, endogenous synthesis from alpha-linolenic acid, transport within the blood for delivery to placental tissues, placental tissue uptake, and transfer to cord blood. Several case control studies have demonstrated that during the third trimester or postpartum, blood levels of omega-3 fatty acids are reduced in mothers with preeclampsia compared to normal pregnancy. During preeclampsia, there may be a downregulation of the capacity to transport lipids in the placenta, and even a reduced capacity of the lipids altogether. Despite this information, there are no solid recommendations for early intervention with EPA and DHA. Many factors were found to contribute to the development of preeclampsia. Some of these were unpreventable, such as family history, and some were, such as dietary intake. These nutrients that have been shown to be preventative against preeclampsia are not consumed enough by these women, and to make it even worse, their absorption and transport is hindered once preeclampsia develops. These preventable factors are ineffective without proper education, which lies on us as nutrition experts. Despite the findings from these studies, it is still not enough to create an adequate recommendation for preeclampsia prevention. So, of course, more research is needed to solidify them. In conclusion, all women pregnant or who are planning to become pregnant need to be encouraged to seek out proper nutrition counseling and screening during their pregnancy. Here are the references that I used, and thank you all so much for listening. If you would like, I could let everyone know what my email is in case you have any questions later on, but does anyone have any questions for me right now?
Yeah, and thank you for a wonderful presentation, Chloe. My name is Lauren Gethin, and I'm another one of the dietetic interns helping out with this event. And I just wanted to hop on really quick before Chloe started answering questions and mention a couple things. So if you don't have any questions at this time, feel free to leave this meeting room. and take a break before the next round. And the next presentations will start at 10:25. And then also Flora put into the chat box an evaluation link, and we would really appreciate it if at some point today you would take a couple minutes to fill that out just to give Chloe some feedback on her presentation. And then other than that, that is all I have. So if anyone has any questions, feel free to ask them or put them in the chat box.
So, hey, Chloe, this is Beth from Outagamie County, and I just had a quick question. If anything in your research, did you find that the timing of conception made a difference with the vitamin D intakes and the effect on the preeclampsia, looking if someone had conceived in the summer versus conceiving in the winter? Did they measure that, or did they take that into a consideration and factor? And then just to let you answer that one, then there's another follow-up question as far as with the vitamin D supplements.
Yeah, so actually, I wondered the same thing because, considering prenatal vitamins, we would encourage people to start that way before they would, start trying to conceive. The only thing that they mentioned in that article that I read was that supplementation became ineffective after 20 weeks. So it was really interesting how they didn't start supplementation, anytime earlier, or they didn't take into account the different times the women became pregnant. They only cared about basically how far along in gestation they were. So no, that's a very interesting realization.
Oh, sorry, my mute is going funny. The other question was just if they had the supplementation taken into account for the controlled group and the placebo groups in there to see how that was taken into consideration, just looking at higher levels in the summer versus higher levels in our lower levels in the winter months. So as a public health, vitamin D has become one of our new little key nutrients. So always interesting. So great job.
Right. Thank you.